Hi, welcome to APP virtual lectures. My name is Lauren Massimo. I'm an associate professor at the University of Pennsylvania, and I co-direct the University of Pennsylvania Frontotemporal Degeneration Center. Today, I'm going to be talking about frontotemporal degeneration. And I have no actual or potential conflicts that are related to this presentation. So here is our outline for our presentation today. First, I'm going to provide an overview of frontotemporal degeneration, or I'll just shorten it now and say FTD, the disorders, primarily focusing on behavioral variant and primary progressive aphasia. Then I'm going to talk about some strategies, non-pharmacological approaches for common behavioral symptoms and speech and language symptoms. And then I'm going to talk about special psychosocial needs that are specific to caregivers of persons with FTD. So just to get started with our overview of FTD, frontotemporal degeneration describes a group of disorders that's caused by disease in the frontal and temporal lobes of the brain. It's a common cause of young onset dementia, which means that on average, we see symptom onset in individuals who are younger than age 65. FTD is a progressive neurodegenerative condition, and unfortunately, at this time, there's no known cure. On average, the life expectancy is somewhere between 7 and 8 years from the time when symptoms are first noticed, oftentimes by a loved one, and until the time of death. And I'm going to go into the stages of FTD later on in this presentation. As you see here, there are two major phenotypes, and that is behavioral variant frontotemporal degeneration, or BVFTD. And this is a disorder that primarily affects, as the name implies, behavior and social functioning. And then we have primary progressive aphasias that includes 3 different disorders that causes progressive aphasia, or a loss of speech and language. And I'm going to go into these 2 clinical syndromes in more detail later on.
Okay, we often get asked about what causes FTD, and there are 2 proteins that accumulate in the brain and cause atrophy, which you see here in this image. So if you looked at this brain under the microscope, you would see one of 2 proteins. So these proteins are tau and TDP-43. For BVFTD specifically, it's really the flip of a coin who has tau and who has TDP-43. So 50% of the patients that we see have underlying tau pathology in their brain, while 50% of the patients that we see with BVFTD have TDP-43 pathology. Generally speaking, certain subtypes of PPA are associated with tau or TDP-43 neuropathology. So for example, semantic variant primary progressive aphasia is most often caused by TDP-43 pathology, and the non-fluent agrammatic form of PPA is most often caused by tau pathology. And again, I'm going to go over this information a little bit later. Now, in some cases, those changes in tau and TDP-43 result from a mutation in an individual's genes. So about 40% of cases of frontotemporal degeneration are familial, meaning that there's a family history of a dementia, a major psychiatric condition, or progressive changes in movement. The 3 most common genes that cause FTD are C9orf72, and this is a cause of not only frontotemporal degeneration, but also ALS, Lou Gehrig's disease. Progranulin is the other mutation, second mutation that causes familial FTD, and MAPT. So it's important for healthcare providers to be aware of the genetics of FTD because there may be potential benefits to knowing about a genetic diagnosis. First, it can mean the answer to a diagnostic odyssey, so the answer to why someone has FTD. Second, it can provide information about other symptoms that they may be at risk for. For example, I just mentioned that C9orf72 can occur in individuals with FTD and ALS, and we know that individuals with this particular gene are who have FTD are also at risk for going on to develop ALS as well. Knowing the genetic stats can also open up avenues for clinical trial eligibility. And this is a really exciting area of science that's going on right now. And I'm going to also get into that a little bit later. And then importantly, knowing if there's a genetic mutation might be important for reproductive planning for a person with FTD or for their family members. And so while clinicians can simply order genetic testing, I think the best practice is really a referral to a genetic counselor because they really know the right type of test to order and how to interpret the genetic results. And then they're able to guide the patient and family on other life planning issues that I mentioned. So now I'm going to turn to the clinical presentation of FTD, and it's important that we think about the brain anatomy and the function of the brain in particular lobes, frontal and the temporal lobes, because this can really help us to understand the symptoms that we see in individuals with FTD. So here, clearly, we're looking at the front of the brain and the back of the brain, and we're looking at the left side here. And we know that the front of the brain is, in the frontal lobes, important for a higher order cognitive functioning called executive function, which allows us to do things like plan and organize and make strategic decisions. The frontal lobe's also really important for personality, regulating emotions, and making sound judgments. The temporal lobe, particularly on the left side, we know is important for speech and language. And so here is an MRI picture of someone with FTD. And here you can see that the frontal lobe is disproportionately smaller compared to the back of the brain, which suggests that there's atrophy here. And this is a picture of a picture of an MRI that we see in individuals with behavioral variant FTD. So it's not surprising then that the criteria for BVFTD includes behavioral features and executive function deficits. So to make a diagnosis of BVFTD, you need to have at least 3 of these 6 boxes checked. And you see that there are just a range of possibilities here from disinhibition to apathy. So I'm going to quickly go through each one of these. Behavioral disinhibition, these patients frequently exhibit impulsivity. They can appear to have no filter. They can walk up to strangers on the streets and tell inappropriate jokes. Apathy, we see loss of motivation or complete indifference to activities that patients were once interested in. They may sit around all day and want to engage in very little activity. We could see loss of empathy. Patients can have really poor insight or self-awareness, and so they can see nothing wrong with their inappropriate behavior, even when their caregivers are super stressed and by their behaviors. Patients can seem to be very cold, even to their loved ones. There can be stereotype behavior like repetitive movements, such as tapping or rubbing. Sometimes there's even complex ritualistic behaviors where this can center around food, where a patient has to eat a certain food at a certain time of day. And lastly, the neuropsychological profile shows executive deficits with relative sparing of memory. And so these are the criteria that we use to diagnose someone with behavioral variant frontotemporal degeneration that was published by Rakowski et al. In 2011. So I'm going to go into a little bit more detail in each one of these behaviors. Disinhibition, again, is a term that we use to describe behavior that demonstrates a lack of restraint. So oftentimes we see a loss of social manner or impulsive behavior, such as conversations that are interrupted or taken out of turn, and this can be really frustrating for caregivers. There can be impulsive behavior, such as impulsive buying or even shoplifting in individuals. Apathy is probably the most common behavior that we see in individuals with behavioral variant FTD. In apathetic persons, we see passivity, loss of interest, loss of engagement in activities, as I mentioned before, and a general lack of motivation. What's interesting is these patients with apathy can look like they're depressed, but they don't have that general dysphoria or sadness that we see in persons with depression. There can be a loss of empathy, and this tends to develop early on in behavioral variant FTD. And this is really one of the most frustrating behaviors for caregivers because they feel like their loved one just doesn't care. There can be an indifference to their loved one. There's a loss of emotional warmth or even sympathy for what other people may be experiencing. Even sad and tragic events like a death in the family, persons with BVFTD can seem to be unaffected by. Compulsive behavior, performing the same act over and over again. So some common compulsive behaviors that we see are simple repetitive behaviors like hand rubbing or leg slapping or humming the same tune over and over again. And there can also be complex ritualistic behavior like having to visit the same restaurant, to have the same meal at the same time of day. And we can even see frequent trips to the bathroom be a form of ritualistic behavior. Hyperoral behavior can be quite common in individuals with behavioral variant FTD, and this can range from consuming large amounts of food and shoveling it very quickly into their mouth, or a tendency to prefer carbohydrates or sweets. For some patients, we even see that they may eat inedible objects or forms of food that shouldn't be eaten, like pet food, for example. So that was behavioral variant frontotemporal degeneration, and now I'm going to turn to the primary progressive aphasias, or the PPAs. So we call it primary progressive aphasia, right? We'll start with primary, meaning that it's not due to a neurological or a medical etiology, like from a stroke, for example. It's progressive in nature, meaning that it is insidious in its onset, and it's neurodegenerative, so it's slowly worsening over time as the pathologies accumulate in the brain. And then aphasia, because language is the presenting symptom and the symptom that initially causes the most disability in the patient. And there is a very nice APP to APP lecture by Sharon Best on the primary progressive aphasias if you want to learn more. So I'll start with, again, there are 3 different PPA syndromes, and I'm going to start first with the non-fluent agrammatic primary progressive aphasia. So in these patients, we hear speech that is slow and hesitant. These patients have difficulty getting their words out. There can be problems with grammar, or they can make mistakes in their spelling. And so sometimes patients will come into our clinic and say that they've been having problems with like sending text messages or in emails because of spelling issues. There can be motor speech difficulties or dysarthria. And the supportive imaging of the non-fluent agrammatic PPA is atrophy in the left inferior frontal lobe and the insula. And as I mentioned before, with the primary progressive aphasias, we can often link primary progressive aphasias to underlying pathology. And oftentimes the underlying pathology in individuals with non-fluent agrammatic primary progressive aphasia is a tauopathy. In contrast, a different form of primary progressive aphasia is semantic variant primary progressive aphasia, where patients lose an understanding of the meaning of words and objects. So their speech, unlike the non-fluent variant, can sound normal and can be fluent. But if you listen closely to the content, there can be empty speech or speech with lack of meaning. So speech that is empty or uses words that lack meaning. So these patients can, again, have difficulty understanding the meaning of words. So they also have difficulty with comprehension. And so you can say, for example, could you please pass me the broccoli? And they may not understand what you mean by broccoli. The supportive imaging here in individuals with semantic variant primary progressive aphasia is atrophy in the anterior temporal lobe. And the pathology most often is linked to TDP 43. The last subtype of primary progressive aphasia is logopenic variant primary progressive aphasia. And here there's a variable amount of fluency. So they may not be as slow as the non-fluent variant primary progressive aphasia, but the speech rate may be slower, may be held up because of their word finding difficulty. So there may be circumlocutions or talking around the word. So for example, if we want to come up with the word watch, we may talk around it by saying, you know, that thing that I use with the numbers, it's on my wrist. So this is, again, more of a word retrieval issue. And again, unlike semantic variant primary progressive aphasia, there is preserved object knowledge in logopenic variant primary progressive aphasia. And unlike the non-fluent variant primary progressive aphasia, in logopenic variant, there is preserved motor speech. Supportive imaging in logopenic variant primary progressive aphasia is in the inferior parietal lobe. And interestingly, the pathology most often is Alzheimer's disease pathology. So we consider logopenic variant primary progressive aphasia, while it falls under the FTD spectrum disorders, it's pathologically, it is associated with Alzheimer's disease. So it can be considered an atypical form of Alzheimer's disease. Unfortunately, all of these FTD disorders are progressive and they will get worse over time. Again, I previously mentioned that the time from symptom onset, or the time when loved ones or the patient first notice symptoms, until the time of death is somewhere around 7 to 8 years. The question that we often get asked is from caregivers and from patients is what stage of the disease their loved one is in. So similar to other dementias, we think of the disease in 4 stages. And these stages are often defined by how much the person with FTD relies on their loved one for their activities of daily living. So things like eating and bathing and dressing. So here you see that the mild stage is the longest stage, and that's because there are compensatory mechanisms in the brain that enable the person with FTD to be relatively independent for almost over half of the disease trajectory. As we move through the stages of the disease, each stage tends to be shorter than the last one, with the affected person requiring more and more assistance. So now I'll briefly describe what you may see in each stage of FTD. So in the mild stage, there are subtle changes that were typically restricted to the domain of difficulty that brought the patient into the office in the first place. So for example, there may be difficulty with performing tasks at work. At home, there may be difficulty with performing complex activities like paying bills or managing checkbooks, right? So those types of activities that rely heavily on executive function. In the moderate stage, activities become more of a collaborative effort here. Here, folks may need more prompting through activities. So caregivers are going to have to directly supervise dressing or grooming. And here, sometimes we see different symptoms may emerge. So for example, for someone with behavioral variant FTD who primarily started with behavior symptoms and executive difficulties, they may also now develop speech and language problems in the moderate stage. In the severe stage, persons with FTD now need hands-on help to complete activities, like assistance getting their arm into sleeves and help with buttons. And here's often where we see incontinence emerge. And in the profound stage, there's a need for complete assistance with activities of daily living. Oftentimes, the individual with FTD is immobile and is bedbound. We also often get asked about what are the major causes of mortality in individuals with FTD, and those include swallowing difficulty that leads to aspiration pneumonia, urinary tract infections that can cause sepsis, and falls. So now that we've reviewed the symptoms and you have a sense of the disease course, I want to spend some time talking about how to support the person with FTD and their caregivers through non-pharmacological management of symptoms, and we're going to start with behavior. So here are just some general strategies for managing behaviors that we talk a lot about in our clinics. People with cognitive impairment, we know, benefit from a regular routine that is predictable. So this includes a schedule of activities that can keep the person with FTD engaged throughout the day. We'll often enlist the help of an occupational therapist or speech therapist to help the patient and the caregiver to develop a curriculum of individualized and meaningful activities that are tailored to the person's cognitive and functional abilities. I think that is really key. There's not like a one-size-fits-all approach, but we really need to think about tailoring of activities to an individual. And then another thing I think that's really important that I talk a lot about in our clinic is that this is not about opposition from the person with FTD. It's not about resistance. The behavior is really a direct result of the disease in the brain. I think a lot of times these behaviors, particularly the apathy and the disinhibition and the loss of empathy, are so hurtful and can appear to be so meaningful and so intentional to caregivers. And we want to be able to, I think, help the caregiver understand that these behaviors are not intentional, and that, again, that it's a direct result of the pathology in the brain. Some other ways to support the person with FTD who have executive function difficulty that may be unable to plan and to carry out their daily tasks. We talk about giving explicit directions for a task. So even something like getting dressed that we think might be so easy, there may be a couple of different steps involved in just getting dressed, right? And so we talk with families and caregivers about the importance of kind of breaking down a task, even like dressing. Creating checklists of daily activities and crossing off the tasks as they're completed. People with executive impairment, we know, are going to take longer to complete tasks. And sometimes this can be frustrating for the patient and for the caregiver. And so it's really important that the caregiver builds in extra time for activities. Persons with executive impairment, we know, are going to have a lot of difficulty making choices. And so it's important to constrain choices to either one or two options, or asking for a yes or no instead of leaving the question to be open-ended. So for example, instead of say, would you like some chicken, right? Which you would hopefully get a yes or no answer, instead of an open-ended question like, what would you like for dinner? Distractions in the environment can really contribute to inattention, which we know is already problematic in individuals with FTD, and distractions can be really overwhelming. So it's important to be mindful of the amount of noise in the environment. So for example, if you're having a conversation with an individual with FTD, it's important to think about doing that in a quiet place without a lot of people around. So now I want to turn to managing impulsivity and behaviors like disinhibition, ritualistic behavior, and hyperorality, which are associated with poor impulse control. First, we talk with our families about maintaining a behavior log so that you can identify any patterns in the behavior or potential triggers. So for example, crowds are often a trigger and can induce impulsive behaviors. We often suggest to our families to go to places during off hours. So for example, instead of going to a restaurant during peak hours, you want to consider visiting at a time that's less crowded. There are cards that families can provide to servers or to staff to let other people that are interacting with the person with FTD know that their behavior is due to a neurological disease. And there are awareness cards that are available on the Association for Frontotemporal Degeneration website that can be really useful. Patients with FTD, as I mentioned before, are easily distractible. But sometimes caregivers can use this in their favor. So if persons with FTD are perseverating on a topic, you can try redirecting their attention elsewhere. For those individuals with those simple repetitive behavior, like the hand rubbing or leg rubbing or tapping of their hands, oftentimes we'll suggest to offer substitution like fidget spinners or other sensory stress toys. For individuals who are hyperoral and eat large amounts of foods or eat foods quickly, it's important to try to control the amount of food that's in front of the patient by putting smaller portions on the plate and then just offering seconds if they're still hungry. And lastly, it's important to try to help the caregiver to understand that it's not helpful to try to reason with the person with FTD. Again, oftentimes there's very little insight or self-awareness by the person with FTD. And so trying to reason with the person with FTD just often leads to more frustration. I'm going to spend some time now talking about apathy, since it is probably the most common symptom that we see in individuals with FTD. Our research and others demonstrates that apathy arises when there's 3 different cognitive mechanisms that are disrupted. So first, we see initiation difficulty or problems getting going on a task. And we find that initiation can be improved by external sensory cueing. And there's some evidence for this in Parkinson's disease, where those patients also have a lot of difficulty with initiation. So external sensory cues are those externally initiated prompts like auditory prompting or visual stimulation to get the patient going on an activity. In the same regard, enhancing the sensory signal by using a multisensory stimulation approach may be useful to activate the person with apathy. So sometimes we see multisensory stimulation used in nursing home settings, for example, where they do things like blow bubbles and touch Play-Doh and finger paint to encourage activation. At the same time, they're like listening to music. As mentioned, persons with FTD can have executive difficulty, and this can contribute to their apathy because they are unable to plan or carry out their tasks. So for persons with planning impairment who already have difficulty with the mental manipulation of an activity, right, figuring out the steps, it's important to think about their cognitive limitations, again, and prescribe their activities that are based on their strength. And as I mentioned before, this is where therapists like occupational therapy and speech and language pathologists and recreational therapists are really a great resource for this. As I mentioned before, individuals with executive difficulties are already disorganized, and they really need to be in a structured environment where their choices are constrained and activities are done in a straightforward step-by-step manner with frequent cueing. And we also see that problems with motivation can be contributing to apathy in individuals with FTD, where individuals with FTD may be insensitive to negative consequences like disapproval from a spouse. So for individuals where we want to target motivation, it's important to think about what types of activities are rewarding to the patient and to use rewards to encourage the patient. So again, we tend to see that negative consequences, that there's an insensitivity to negative consequences in individuals with FTD, but there still be motivation from using rewards. Oftentimes, as I mentioned, individuals with FTD are hyperoral, and so food or gum can be a good motivator in this population. And lastly, there's some research to indicate that music therapy, especially music that is live and interactive, and physical activity have also been shown to improve apathy. So next, I'm going to turn to discussing some strategies for those individuals with primary progressive aphasia. So for patients who are having difficulty with comprehension, again, we often see this in individuals with semantic variant primary progressive aphasia. They have difficulty with comprehension early on in their disease course. And then individuals with the other FTD syndromes, unfortunately, will develop comprehension difficulty as their disease progresses. So this would be relevant for individuals with behavioral variant FTD as their disease progresses, and individuals with the non-fluent variant primary progressive aphasia and logopenic variant primary progressive aphasia. So some strategies to think about as you're talking with your patients and with caregivers. You want to encourage them to speak slowly, to give the individual who's having comprehension difficulty enough time to process what is being said. Use shorter sentences and keep those sentences simple. So keep the information simple and straightforward, speaking redundantly. So if you're not getting anywhere with giving instructions one way, try to say the same thing in a different way. Speak in context. So if you're having a conversation about having dinner, it's oftentimes helpful to have that conversation in the kitchen. That way you can use gestures. Pointing to foods are often a good way, again, to increase comprehension. The nonverbal cues are really important. So again, getting back to the gestures, nonverbal cues such as eye contact and smiles, even up until the late stages of FTD, individuals are still able to understand smiles and facial expressions. And then lastly, the use of picture cards, again, where the individual can point to what they want. For patients with speech difficulties, like in non-fluent variant primary progressive aphasia and logopenic variant primary progressive aphasia, where they have difficulty getting the words out or finding the words that they want to use, it's important to give the patients time, right? It can be very frustrating for the patients as they're trying to get the words out, but it's important for the caregiver to just allow time and time your support. So just not just jump right in and say, oh, are you talking about going to visit our daughter? You know, just give them time to get the words out. Written communication can be helpful. Computer assistive devices, and this is where, again, referral to speech and language pathologists can be helpful. The psychosocial needs of persons with FTD and caregivers are really quite unique, and so I do want to spend a little bit of time talking about this. In addition to this devastating loss of personality in their loved one and significant behavior and language challenges, FTD caregivers have to they face unique challenges which are particularly stressful. And in many studies, individuals with FTD, caregivers of persons with FTD have higher levels of stress and burden and depression than caregivers of other forms of dementia. And that's probably due to a host of reasons. So first, there's really limited community awareness. So people hear about the word dementia, frontotemporal dementia, and they think about Alzheimer's disease. They rarely have any knowledge about early onset dementias like FTD, and so this lack of knowledge can be really frustrating for caregivers and can be really isolating. Caregivers often cite that behaviors like disinhibition are embarrassing, and they may prefer to stay home. And so again, you can imagine that this can also be isolating for caregivers. Community support services for persons with dementia are oftentimes developed for older people with Alzheimer's disease, and therefore may not be appropriate for younger persons with FTD. And this can be a real challenge for caregivers. For many patients that we see, their PCPs or their specialists may oftentimes miss signs of FTD, and it can take patients years to receive the right diagnosis. So oftentimes we see that patients can take anywhere between 3 to 5 years to arrive at the diagnosis of FTD, and that journey can be really challenging and frustrating for patients and caregivers. Other unique aspects of caring for an individual with FTD is the behaviors, right? So many of these patients have poor judgment. They can have excessive spending habits. We can see patients engage in very risky behaviors like reckless driving or engaging with scammers. And We've unfortunately had patients that have spent their life savings, lost their life savings because of a scam. Treating a person with FTD also means caring for the caregiver. Life as an FTD caregiver is really filled with very significant and unique challenges that I just outlined that are just extraordinarily stressful. There are challenges that are associated with the day-to-day caregiving tasks, right? Like dressing and bathing and toileting, but they also have to manage managing the behavioral symptoms as well, which are extraordinarily stressful for caregivers. Taking on a role as a caregiver is never really easy, but particularly in this younger population, many caregivers have children at home, and they may also be taking care of their elderly parents. So this can be extraordinarily difficult. There can be the cognitive and the behavioral changes that occur in an individual with FTD, like loss of empathy, apathy, and disinhibition, can really change the relationship between the spouses. So, for example, loss of empathy in a person with FTD can really make it difficult to maintain a sense of connectedness in relationships. And remember, these patients are in the prime earning years, and there can be financial strain that's related to their loss of income. And oftentimes caregivers may also have to reduce their hours or leave their jobs to become caregivers. So there can be major financial strain as well in this younger population. Just want to spend a couple of minutes talking about the research landscape for FTD. This is really an exciting time for FTD research. If you look on clinicaltrials.gov right now, there's over 300 studies that are listed. That includes observational trials and treatment trials. And it's really been an exciting time. Over the last, I'd say, 10 years, there's been progress in growing these large multi-institution consortium that aim to collect unified data, to collect patient data, so cognitive data, MRI data, biofluid biomarker data, that we really need to understand the natural history of FTD that is needed in order to advance knowledge for future clinical trials. And the consortium in the United States is called All-FTD. There's been a lot of excitement in the biomarker area. So biomarkers are indicators of underlying pathological processes, and it's really important for us to be able to develop specific and reliable biomarkers that allows us to first differentiate FTD from other forms of dementias, and then second, to be able to identify FTD tau and from FTD TDP43. So again, important for us to be able to predict who has underlying tau and who has underlying TDP43 pathology. So right now we are pretty good at detecting Alzheimer's disease. So right now we can use CSF, and we can use amyloid PET scan when we see individuals and we're unsure if it is Alzheimer's disease or if it is an FTD spectrum disorder. But there's a lot of research and momentum in trying to figure out tests where we can reliably distinguish FTD tau from FTD TDP43. And lastly, the therapies that are in clinical trials are mostly for genetic forms of FTD. So at the University of Pennsylvania, for example, we have clinical trials in disease-modifying treatments that seek to boost progranulin in individuals with progranulin mutations. So this is right now at Penn done through two mechanisms. First, treatment with an antibody to increase progranulin, and we also have gene therapy clinical trials for individuals with progranulin mutations. Important resources to provide individuals diagnosed with FTD and their families. The University of Pennsylvania Frontotemporal Degeneration Center, The Association for Frontotemporal Degeneration, or the AFTD, has a great website with a lot of terrific resources. The Remember Me podcast for those individuals who may prefer to access educational information through podcasts, were started by two women who whose parents were affected by FTD. That is a terrific resource. And then the book, What If It's Not Alzheimer's, that's dedicated specifically for individuals with FTD. And lastly, I'd like to acknowledge some of the work that we do at the University of Pennsylvania that is supported by a very large team of dedicated researchers who study frontotemporal degeneration disorders and are sources of funding support. Thanks so much for your attention. I hope that this was helpful.